things change throughout the day. We might not get everybody, and I'm conscious that you've been so gracious to join us on time. So I think we'll kick off, Tom, if you're happy to.
Absolutely, yeah.
Fabulous. So welcome to the second half of this series for Empowered Leadership for Safe, Compassionate Care with our host, Tom Bell, who is founder and director of Cormetis Consulting. Tom is also a member of the Institute. I'm Jade Maloney, operations manager, who's on hand to facilitate the tech side of things today. It is designed to be an interactive workshop, so as always, we'd love to see you, hear from you, share your comments in the chat box when there's opportunities to contribute to some activities that you can unmute and freely contribute. If there is anything said during the meeting that you would not like published, then you can contact me and I can edit that out of the recording, because that will be circulated to all delegates, including a slide deck as well that Tom will be using today. So this session is all around engaging compassionately with those affected by poor care. We'll be talking around the emotional, psychological and physical effect of that for service users and their family. We'll be learning some of the principles of engaging with those people empathically, with respect and understanding, and developing some of those active listening skills. And also understanding the importance of ownership when things do go wrong and how to be committed to improvement and why that is so important. Tom, I want to hand straight over to you now. By way of raising hand, did anybody got any questions? Lovely. Tom, over to you. Thank you.
Thank you very much for that introduction, Jane. That's greatly appreciated. Before I get into the slides as well, I should say, this is a topic that's particularly close to my heart, and I always like working with the Institute, but I especially love it when I've got an opportunity to talk about something like this, which I think really resonates on a human level. There's something here, I think, about compassionate engagement that will take us outside of our work environments and hopefully outside of the traditional ways that we think. So I will start to share my slides. We're going to have a couple of opportunities, sort of question points, if you want to call them that, as we're going through, and those will be fairly early on. And then I've left quite a few minutes at the end, and we're a select audience today. That's a good way of putting it, isn't it? We're a select audience today. So at the end, I'll leave quite a few minutes for what I hope will be a good discussion with you. So here we are. Now, hopefully you can see that okay, yeah. Wonderful. That's a thumbs up from Jade. So thank you very much for that. This is, for those of you that haven't attended previous ones, this is the fifth in a series of 8 bite-sized workshops. And the series was designed so that each workshop would complement and build on each other. And I wanted each workshop to provide in the limited time that it has, because people are busy and we get that. But I wanted to provide a mix of behavioural insights, useful behavioural insights, some practical knowledge and some usable takeaways in a compact format. And my hope is that what we do today is helpful to you in the here and now, as well as thought-provoking for the future. So let's talk about engaging compassionately with those affected by poor care. Perhaps more than any other, this is an area in which I have a great deal of experience, not wanted experience, I have to say. So that's perhaps another thing to bear in mind. But it's also in my experience and in the experience of many others that I meet and talk with, and I'm speaking constantly to people both within the NHS, within the care sector, within the wider health and care sector. It's something that health and care services consistently fail to do well, to engage compassionately with those affected by poor care. I don't think it would be unfair, and we can perhaps discuss this later, but I don't think it would be unfair to say that healthcare services have a terrible track record in this area. And I hope to bring the significance of this to life as best I can. So I have a quick agenda here for you to have a shufti at. We're going to do a quick recap on where we're at in terms of this particular course. Then we're going to ask a question about the right to withhold information. You can see we're going to get into there the impacts, what's meant by compassionate engagement, humble communication, taking ownership. I try to end my presentations with things you can do, some things you can think about, and some useful reading, and you can kind of take some, hopefully take something from that. and then discussion and idea sharing. So here's a screenshot of the series up to press. And in the most recent workshops, we talked about what are essentially internal issues, things we can do to make the organisation better at what it does by making it a better place for employees. And we're now going to turn our gaze out from the organisations that we work in. And in this and the next workshop, we're looking at how we engage with the patients and service users. And then the next workshop is about the wider system stakeholders. The logic behind this approach that I hope is beginning to become clear to those who've attended previous sessions is that as services and organisations, how we engage with ourselves in the organisation dictates how we engage externally. The sum of our external engagement, if you like, is the sum of our internal engagements. We can't be terrible at engaging internally and brilliant at engaging externally. It's an organisational competence that we are somewhere on a continuum of, and that we can't be brilliant at in one place and not in another. Sweeping statement, I know, and perhaps again one to discuss. But if we aren't compassionate with each other, there'll be very little scope or emotional capacity or headspace to be compassionate with others. And organisations that are internally disengaged traditionally are seldom, if ever, able to engage effectively with external stakeholders. Hope that makes sense. So I am just going to stop screen sharing very briefly and just ask who's in the room. And this is great that we've just got the 11 people here. So who's in the room, and is anybody looking for anything particular from this? Feel free to either introduce yourself with a couple of words or to say what you're looking for from this, or if you're not comfortable doing that, that is absolutely fine as well. Shall I start off with Anne? Can I ask Anne? Okay. Go on, Anne, you've got your hand up. That's great.
So unfortunately, as a community nurse, I come across people affected by poor care more than I'd like to think. It happens. Having experienced it also, and friends too. So I think it's something we're addressing all the time. And I think for me, really, I'm trying to be most useful in my response, actually, potentially in how I engage back with the hospital, because our community services are not part of the hospital. We're a separate organisation, but people refer to us when they remember to use the forms. So it's
okay.
I'll give you an indicator. So to continue meeting people's nursing needs in their home. So, but it is about how to have a useful dialogue, actually. That it isn't just about, there's something about letting people know, you want people to learn, etc., etc. Sometimes it feels like the glazing over, there's no capacity to absorb the problem, they're too busy. How to get people to how to be more useful and clever in how we communicate with them, as well as obviously looking after and supporting the people who have experienced the issues, because we have people from minor things to major catastrophic, almost catastrophic, and to prevent us from becoming cynics.
Okay. Yeah.
There you go. Sorry. So no, not a big ask.
You made some excellent points, and I think we can eat into some of them. You'll be pleased to know. So that's good.
Thank you.
Anyone else looking for anything particular from today? Or that's okay. We won't force that one. I will now go back to sharing, and we'll move on. So that should be okay, Jade. Yeah, we're back on. Okay, wonderful. So we've found out who's in the room today. So I've deliberately made this slide opaque because it includes a lot of headlines. I didn't want to do that thing where I laid them all out in lines. I just want to paint the picture here, which, if it needs painting at all, it's a picture I think we're all familiar with. Estimates of how many people are harmed and how significantly, get my teeth in, significantly they are harmed varies, and depending on who you talk to, the number of avoidable deaths in the healthcare services is thought to be anywhere between 11 to 30,000 per annum. The number of people harmed in primary care is pretty much an unknown. There are efforts at establishing that, but in my view, they're pretty inaccurate. I think because in many respects they can't be accurate due to the nature of primary care. And again, we can discuss that later if you wish. Not everyone who's misdiagnosed or unwittingly diagnosed or unwittingly harmed knows they have been, yeah? And I hope that makes sense. And harm will occur not because people are bad, not because the health service is terrible, any part of that health service, be it public, private or third sector, but because we're all human. That's the bottom line here, isn't it? You know, we and our colleagues will make mistakes. That's where we're at. So this chap here, this is Johnny. And Johnny was he was my best friend growing up. He was that annoying friend. I don't know if some of you may have had a friend like this, but he was a very annoying friend in as much as he was better looking, could play the guitar, was attractive, you know, to the opposite sex, which when you're a young man, you know, that was super important at my age. And he could take things apart and put them back together again. And I remember, you know, my first experience of this was when Johnny had a push bike, which needed some adjustments making to it. And he hadn't, you know, he can't have been more than 12 years old. And this push bike was just taken apart and put back together. And I was just standing in the background going, that's never going to come back together. That is not going to work. But it did. And we grew up together. And a few years ago, Johnny tragically took his own life. And his mum found him hanging from one of the beams in the garage at home. And she, as you can imagine, has never got over that. And we're going to come on to the impacts shortly. She has never, ever got over that. And it emerged later that Johnny had been sent home without the consultant being spoken to. So the on-call consultant, mental health consultant, wasn't spoken to. He'd been sent home with medication that exacerbated his risk of suicide. There were a whole host of mistakes made. In short, while we can't say with certainty, what we can say is that Johnny harmed himself and that it was probably avoidable. His mum then spent 5 years pushing the NHS to find out what had happened, and they settled on the court steps. It didn't go through NHS resolutions. His mum felt that they were being so dismissive towards her concerns, and again, this is a part of compassionate engagement, but his mum, Isabel, felt they were being so dismissive of her concerns that she ended up hiring a solicitor. I have to say that the compensation that she got mostly paid the solicitor's fees, yeah, and just a needless 5 years of pain and of expense to find out something which, if people had just engaged compassionately at the start of that process with integrity, would have saved everyone that. You know, the only people that made anything from that were the legal teams. And some of you may recall during a previous workshop, I think it might have been the last one, it was on internal engagement, that I told the story of a chief executive who had told staff in an open management meeting, a large management meeting, where he said, I've got far more important things to do than spend time with you. He said, some of you want me to spend time with you, but I've got far more important things to do. His words, not mine, yeah. Quite the motivator, as you can see. Now, he was the same chief executive that was in charge of the trust on whose watch Johnny died. And after Johnny's death, the chief executive sent a letter offering Isabel, Johnny's mum, his condolences. And in that letter, he had repeated an entire paragraph. So that letter, that crucial, tangible touch point in the process of engagement, hadn't been checked. He had signed it and given it to someone else to send. It's not that the chief exec was a terrible person or inherently bad. It's simply that his attention was focused elsewhere. He was applying the tools that had got him to the point where he'd got. So you must put yourself in someone like that's shoes and ask the question, are they going to change? And the answer is no, they're not. If doing the things they've done has got them where they want to get, they're going to see no need to change. So his focus is very much on the regulators, the commissioners, not the staff, not the service users, not the patients or their families. And I think, again, it's not because that person's bad, but the systems that we work in, they can also easily steal our attention with their demands. You know, we have to feed the beast with targets and numbers. And I think that we have to remain constantly aware of this and constantly challenge ourselves and those around us and keep asking whether or not we are looking in the direction that really matters to the people we serve. And that's a really important point. I'm going to ask a question now. Does anyone have the right to withhold information about an incident from the people who have been affected by it? So again, I'm just going to stop sharing the screen here, just so that we can all sort of look each other in the eye and have a conversation. If someone has suffered harm, inadvertently, deliberately, however, in the care of a healthcare service, Do you think anyone has the right to withhold that information from people? We've got a hand in there already. That's Jacqueline Slater. Hello, Jacqueline. Excuse me.
Isn't that where our duty of candour comes in, that we should be open and honest and let them know when there has been a level of harm?
Yes is the straight answer to that question. Does it always happen? I think that's a rhetorical question, because I think we have duties and we have legislation and we have rules and regs, but actually those rules and regs haven't really changed a great deal. If you wind right back to mid-staffs, and I know I have to say, I think people in healthcare circles are almost tired of talking about mid-staffs, but I saw Robert Francis talking on a session that he did with the Institute for Government the other day, and he's still talking about it, in the sense that he's saying that some of the things from that still haven't happened, that the ways of behaving in some respects have actually got worse. So I think the duty of candour, in theory, I think is a great thing. Let's be candid, let's be open, let's act with integrity. And there is a duty, right? I'm not sure that it's always adhered to. Is that a fair observation on my part, or? Okay. Any other questions on that before I? That's fine. I will go to my next slide. But thank you for that question. Okay, we've got thumbs up again, I'm hoping. So the reason I ask is that not all those who've been affected by or experienced poor care, accidental or otherwise, will even know it. Now I'm going to put my own experiences of being kept in the dark about what happened to my sister Alison to one side for a moment, because I don't want you to think that my views have been shaped entirely by a single episode or by something that's happened in my life, which I now think is typical of the system. I do not want you to think that. I've got the t-shirt, it itches and it scratches, but I appreciate that there's more than just my experience going on here. And what I'm going to do is talk to you very briefly about a well-watched TED talk, which some of you in healthcare circles might have seen. I still watch the TED website. I know it's a bit old, a bit passé now, isn't it? But there's some great stuff on it. And there's a presentation there by a guy called Brian Goldman. Now, the talk is interesting for many reasons, and I'll share a link to it in the PowerPoint presentation, Jade, afterwards. But it seems a very heartfelt talk in which Dr. Goldman, who practices in Canada, he highlights how clinicians in healthcare don't feel able to share or talk about their mistakes openly. And I think that's a sentiment that, and it's a view I think many can identify with. But around 10 minutes into the talk, he says, and it strikes me as in an almost dismissive fashion, he talks about the first incident where he got something very wrong. And he says, after that first incident in which he had made a mistake that cost a patient their life, which happens, this happens, his colleague, who he then goes on to describe as an absolute doll, not sure what that means, but perhaps it's a Canadian thing, who knows. His colleague talked to the family, these are his words, by the way, his colleague talked to the family and I'm quite sure smoothed things over and made sure he didn't get sued. Just have a little think about that. His colleague smoothed things over with the family to make sure he didn't get sued. I think that's absolutely fascinating. It's not that Dr. Goldman is a bad person either, but he's talking about clinicians being able to engage compassionately with each other internally and to understand and acknowledge each other's mistakes and to learn from each other. Yet at the same time, he's saying from a clinical perspective, it was okay to hide what had happened from the people and the families that had been affected by that incident of poor care which avoidable, preventable harm occurred and someone died as a result of that. Someone died by his own admission. He's saying that on the TED website. So it's an interesting thing to bear in mind, I think, isn't it? Not everybody that experiences harm knows they've experienced harm. And I think, that's a great point. Jacqueline, you made it about the duty of candour. You might remember a report a couple of years ago presented to, that's 4 years ago now, isn't it? Gee whiz, where's that time gone? It was presented by MPs to the Houses of Parliament, and it talked about the fact that they estimated about 1,000 infants, babies, each year were dying preventable deaths simply because people were unable to talk about mistakes that had been made internally inside the organisations that they worked for. They were unable to acknowledge things had gone wrong and to discuss them. So if you put that in context and you say, if that's happening within organisations where we're not allowed to acknowledge our mistakes and talk about them, I'm going to guess that's amplified. So when we talk about a duty of candour, if we have that externally, but we don't have it internally, then we're back to that mismatch of saying, well, we can't engage brilliantly externally until we're engaging brilliantly and openly and with integrity internally. So again, I think it's a very interesting point there. yeah, we need to be able to talk about things before we can acknowledge them. Yeah, and if we can't even talk about them, then those things are going to occur and nobody's going to know about them. When I asked about being able to withhold information from people, it comes from a genuine place, in as much as that I'm sometimes asked by people, do I think it would have been better not to have known and not to have found out about what happened to my sister Alison when she was in the care of an NHS mental health hospital, and about the events that preceded her suicide? I won't go into details of that story. If you want to know more afterwards, let me know or get in touch. But I'm often asked, because we only found out, it was nearly a decade after it had happened that we found out, and Alison had already taken her life by that point. And people say, well, what you didn't know didn't harm you, but actually what we didn't know was harming Alison and ultimately harmed us all massively. And we were ignorant of what was going on, and that ultimately ended up costing us more than I can ever put into words. And so I think choosing not to tell people if they or their loved ones were harmed unnecessarily is not compassion. We can call it the greater good, we can call it saving people from hurt, but I don't think it's compassion. I think it's deception. I think it's theft of the truth. And I particularly love that phrase from The Kite Runner. Brilliant film and brilliant book, by the way, which talks about there being only one sin, and that is theft. And that we have no right to steal the truth from other people. I think it's a very powerful message. But of course, the system conundrum exists, doesn't it? Right at the point where the greatest levels of our humanity are needed, yeah, the better nature of health and care services struggles to emerge. Again, not that we're bad people. It's that we exist in systems and organisations that kind of, the edges are jagged. We have what I would call that clinical, compassionate side. That's the bit where, during the COVID pandemic, we had all the graffiti of the nurses with angel wings, Banksy doing pictures of nurses as superheroes, some wonderful stuff going on. But then there's almost that kind of Jekyll and Hyde bit, isn't there, where we need that compassionate bit in the interactions that occur through the bureaucratic points, the admin points, the leadership points, the management points, all those process points that exist in NHS and other care organisations. Because people's perceptions, whether you're dealing with a care home, a healthcare setting, a primary care practice, our perceptions are shaped by what we call the touch points, our moments of experience with each of those things. Yeah, and a touch point is a point of contact or interaction, especially between an organisation and the users of its services. Yeah, and every touch point should reinflect and reinforce and reiterate the message you want to give. This is what good brands know. The best brands know this. I can say that, by the way, 20 years as a chartered marketer. Don't hold that against me. But your touch points will give the message of who you are. You don't give the message of who you are and then not have the touch points to back it up. Your touch points are the message of who you are. Yeah. And we discussed previously that an engaged workforce is your greatest asset. I think it's your only asset, to be fair. But the experience of your service users, your patients, their families, friends and loved ones, yeah, they will mirror that of your employees. So, but I appreciate there is a system conundrum there, which often stops us bringing our better selves to the table. But after something's happened, there's a pivotal point in time, and how I think you choose to respond, that really sets the tone, absolutely sets the tone for how things go forward. Even, from choosing to hide things, yeah, to being open and acting with complete transparency and candor and humility, yeah. Now, how this moment goes is so crucial, because a small omission or a hiding of truth or an inaccuracy at this point, something that can even seem inconsequential, could ultimately spark a fire that you will not be able to put out with. It will be beyond your control, perhaps organisationally, reputationally, and it could cause untold harm to many people, emotional harm, moral injury, yeah, including people in your own organisation. Now, to bring this to life, what I mean by this, some of you may have heard this story before, but you imagine that you're a pilot, yeah, indulge me, and you're flying from New York to London. If your heading is off by just 1 degree, after 6 miles, you'll be a mile off course, yeah? If you don't correct the error, then after flying the full 3,459 miles, you'll land in Spain, not London. And my point is that get the trajectory right, get the platform right, that'll set the stage and set the tone for everything that then follows, yeah? If you're off trajectory to start with, you are then in a terrible position. Let me bring that to life for you. When things happened to my sister Alison, what happened was an entirely understandable human error, and because people are human, I say that, people drop the ball, an entirely understandable human error of judgment was made, which was then hidden. And from that point, everything escalates. The growth in the wrongdoing becomes exponential, because everybody then has to work to hide that, because nobody can admit the original mistake for lots and lots of reasons. And before you know it, you've got 3 public organisations all falling over each other to stop things happening because they can't admit their original error. Really horrendous. Computer says no. How many times have we heard that? I think the processes that we put in place of meaningful engagement and the fear, completely unfounded fear, I have to say, that if we apologise and we say sorry and we acknowledge others' feelings, that we in the organisations we work for will somehow be liable for something as yet unknown, and we'll be in trouble personally if we are seen to be off message or we acknowledge something without official permission. You know, these things change the nature of the events from an incident of poor care, perhaps even a tragedy with a person, an individual and their loved ones at its heart, into a process to be managed. And there's a clashing between those two things. So it's at this crucial point that the scene is set for how things then progress. And as I say, the tone needs to be set as early as possible. We in the organisations we work for, we've got to crawl out from behind our defensive shields and shift from being reactive to proactive. We'll step forward. Don't seek to even create the narrative or set the terms of the conversation, but just put the bridges in place and set the tone that will enable meaningful dialogue. And Anne, you talked about dialogue earlier. Dialogue is such an important word and such an important action. You know, dialogue recognises that every interaction has to be unique. And so in a sense there, what you've got is automatic recognition within dialogue that processes the same processes. They won't work for everybody. They won't suit everybody. They won't suit the people at the very heart of what is going on. I want to talk briefly about, and I'm just going to do a quick time check there, forgive me. I'll talk briefly through each of these, and I want to bring them to life with examples. So when we fail to engage meaningfully, openly, with a spirit of humility and an intent to learn, we are creating the conditions in which history will continue to repeat itself. That's what effectively we are doing. So, engaging with compassion is not only the right thing to do, it's actually the most effective and the most efficient thing to do in the long term. Many of you will have heard the argument from quality consultants through the NHS Leadership Academy itself, that quality is actually cheaper than poor quality. Getting things right is actually much cheaper in the long run than getting them wrong, than cutting corners. I think we'd all agree with that. Now, what does he mean by the 4 types of harm? The first type of harm, if we let's look at this, is the person that is harmed, those directly harmed, at whatever level that might be. Second harm is the harm that's incurred on those around them. So in Alison's case, my sister, it would be us, her family, and the friends and the people that loved her. So we've experienced a form of second harm. We weren't harmed directly, but we've experienced a form of second harm through the loss of Alison. Third harm is those in the system. So those people within the system who had to hide what was going on and had to adapt themselves to a culture that to many of them was probably quite alien. Many of them would not want to have hidden what had gone on. But because they're not allowed to talk about things, and if I take you back to that example of maternity failings, where people aren't allowed to talk to each other because we're not acknowledging mistakes, we're not allowed to admit what's gone wrong. I appreciate there are pockets of excellence, but there needs to be a whole lot more. I'm sure we all know that. But we're harming ourselves. And one of the things that you will get from the Brian Goldman speech, if you make some time to look at that completely at your leisure, is that you'll see that they do each other harm by not acknowledging their mistakes. He feels shame. Dr. Brian Goldman talks about the kind of shame, not the shame that you get, that then takes you on to learning, but the shame that you get that makes you feel bad, destructive shame. I'm not sure there is a positive type of shame at all, is there? But he talks about shame being very destructive to all the people within the organisation. So there's harm done to the people who work in the organisation. I'm sure many of you recognise that. Fourth harm is the harm that we could have avoided if we'd taken those lessons learned. We could have stopped history repeating itself. Those yet to be harmed. Now, we can never quantify that. But what we can say is that it is a real factor. If we're not learning from our mistakes through the process of compassionate engagement, then we are simply creating the conditions in which things will happen again and again and again. And the impacts of poor care, vary broadly, and this is incredibly broadly. We talk about physical, we talk about psychological, we talk about social. They exist at all those levels, and they exist in the short term, the medium term, and the longer term, and they vary like waves, and they cross There's no fixed pattern to these things. Sometimes I will, 30 years after it happened, sometimes I'll be on the verge of tears remembering what happened to my sister. My mum has never been the same. My mum has, it's done something to my mother which nobody can ever undo. Now you might say that's a case of, well, perhaps, people need to learn to leave things in the past. You're very welcome to that opinion, and I wouldn't hold that against you. But it is a fact. I can't help what happens. I've done my best. I've been through all the counselling and all the things that I can to help me deal with what happened, but I can't help it hitting me. And in some respects, the fact that it does hit me is just because I'm human, and it reminds me of my sister and who she was and what she could have become. So you've got those impacts of poor care, and they last, and they come in waves, and they spread across. And if we take them with all those types, we talk about the different types of the harms, the first, second, third, and fourth, to a lesser degree the fourth. But if you look at those first three categories of first, second, and third harm, again, you'll see those short, medium, and long-term effects of that. The impacts of poor care, they ripple out. Here's the interesting thing, though. They don't ripple out in a way where the wave gets less. There are points, and this is, I don't mean to depress anybody with this slide. I'm speaking from the heart here. What's lost grows in significance, and what I mean by that is, when I lost my sister Alison, I was a young man, just been married a few years. The older I've got, the more I've experienced of life, the more things I've done, the more experiences I've had with other people, the more other people have enriched my life, the more my understanding of life and of how precious it is has grown. And that's a wonderful thing on an individual level. But it makes me look at Alison and think, wow, what could have been? Look what you missed out on. Look what was taken from you. And so when we talk about what's lost growing in significance, that is essentially what I mean. What is compassion? What is compassion? We all talk about compassionate engagement. It is, for those of you working in the NHS, there's a lot of emphasis on compassionate engagement. And I think it's referenced within, PSERF, strategies, plans, etc. Here are some definitions of compassion. And some of you may have heard me talk about this before. I'm just going to look across at the screen there. It's suffering together. That's quite a strong thing, isn't it? To acknowledge that you're going to suffer together with someone who has experienced something perhaps terrible, something with perhaps lifelong implications, consequences. Displaying compassion means you are taking a position where you are going to suffer with that person. I don't mean you're going to destroy your own life. What I mean is that you express your humanity, that you engage in that process at a human level. And I'm not sure that's anything that a duty or a regulation or a set of criteria can help you do. That's about us and who we are as people. And you can see the difference there between empathy and compassion, which I'm not going to read out to you, but I'm not a big fan of reading slides in total. But compassion takes it that step further. Now, here's another definition of compassion. Going out of your way, to relieve. So it's the absolute opposite of that computer says no. It's actually saying stuff the computer, get the computer off the desk. Let's have a conversation. What can we do? We go the extra mile to relieve the physical and the emotional and the psychological and the social impacts of what has happened. Now, I think what's fascinating about this definition is that you'll notice in it, it says it may be considered partially rational in nature. Isn't that wonderful? I think it's totally rational. I also think you can't fake it. And the reason I think it's totally rational is that I think it's about us recognizing how we'd like to be treated. So when we respond to others the way that we'd like to be treated, I think that is totally, totally rational. And as I say, I think because it's rational, because it's human, I don't think it can be faked. Now, compassionate engagement is not, when you engage, we're not engaging for engaging's sake or to tick a box. Compassionate engagement, as well as being an end in itself, and it is an end in itself. You don't have to, to engage compassionately is to engage at a human level, which will leave an impact in itself. But it's also the means by which you can make a difference. You see, we talk about that trajectory, and if you can set that trajectory for a very different sequence of events than the one that all too typically occurs, you can help people heal. You have an opportunity to create that meaningful human experience and change the perspective and, really importantly, the emotional legacy that's going to be left behind. There's a legacy. Events create legacies, and how those are handled at that crucial point where they occur. That's the platform on which the legacy gets built, yeah? So it's more than just listening or demonstrating empathy. It's practical, and it combines good, coherent processes. So processes are important, yes, but with a human touch. And it's not your role to smooth things over and leave people to wonder for the rest of their lives if they did the right thing, yeah? We should be giving them all the information, tools and support they need to equip them, to empower them, to make their own informed decisions about what to do next. We shouldn't be setting the narrative or smoothing things over. It's about empowering them, sometimes with information which might be contrary to our gut instinct. I don't want to tell them that. I don't want to share that with them. I don't want them to go down that path. That will be bad for us. That's not compassionate engagement. That's backside covering, yeah? The detail matters as much as the delivery, yeah? Not everyone's going to want the same level of support. That's okay. But as long as they are made aware of what's available in a consistent fashion, in a coherent fashion, some will disengage, some will rage, some will retreat, yeah? People cope in different ways. Compassionate engagement means being willing to adapt your style of communication and engagement to meet the needs of the person, yeah? To fit with them. Don't demand that they fit with you and your processes. That's not compassionate engagement. And when I say the detail matters as much as the delivery, go back to that example of the letter. When Johnny's mum read that letter and realised that it hadn't even been sense checked and that it was just a cut and paste, really sorry, you know, your son's dead. Hey, I'm really sorry. Cut and paste. That just, I mean, that to her was just devastating. It was horrible. What do we mean by authentic, humble communication? Humility is a much underrated quality in health service management. And I think what tends to happen within care services, within healthcare services, whether it's primary care, care homes, hospital settings, community services even, is that I think that when things go wrong, there's a sort of a transfer of responsibility for what happens next to the admin side, to the bureaucratic side, to the management side, which is essential. Services can't be managed without that. But there's not a great deal of humility present sometimes in those areas because humility isn't rewarded. It's not that kind of culture, not that kind of climate. Pull me up on that if you wish, absolutely fine with that. But in my experience, there's not a great deal of humility. And humility really for me is engaging on the basis that you've got more to learn than to offer. Yeah, you know, you're there to learn, to understand what's happened, to see things through other people's eyes. Acknowledge people's right to be angry, yeah. You know, I remember having a conversation with the steering group of the Parliamentary Health Service Ombudsman, you know, which they were talking about the kind of language they use in their letters, you know, and it really is, and forgive me if I'm just sense checking for time, but if you're not comfortable with fruity language, then, you know, mute me for the next 30 seconds. But we talked about the use of their language and they said, you know, Tom, were you disappointed? And I said, I was more than disappointed. So disappointment is something you feel when the Bluetooth connection on your car doesn't work or link up with your phone. I said, I was fucking devastated. I was reduced to nothing. You know, I was a wreck, sat on the foot of the stairs, crying, you know, disappointed doesn't get near it. So processes and rationality, please don't try and apply those over people's emotions. Give them space. Processes and emotions, they're like oil and water. You know, simply listen to, or if they're writing to you, read what they have to say and try to stand in their shoes with them. And that's a super difficult thing to do, which we're going to come on to. But, you know, we've got to be humble in these things. The worst thing we can do is that kind of arrogance where, you know, you're in a process now and we'll deal with it. And it doesn't help. It really does not help. I can't help wondering, actually, and there is some empirical evidence to support this, the current bill of liabilities for NHS resolutions, I think there's a huge chunk of that would never exist if organisations had engaged humbly with people after incidents of poor care had occurred. You know, that's, by the way, that's, you know, I put that slide up there. You can see over 50 points of contact across 4 organisations in a year. I now have, at the last count, over 4,500 emails in my inbox. That includes, and that, by the way, doesn't include the correspondence and the letters and the files and the other stuff that I have separately. 4,500 emails in my inbox. And I would say a good 2/3 of them are because of a lack of ownership. Nobody will say, I'll help you through this. Nobody just puts their hand in the air and says, I'm here to help you through this. I understand this is going to be difficult for you, and I understand your emotions are going to be high, and I'm here to help you through this. It really is, if you want to know what entering the territory of computer says no is like, then, step into my life for a week or so. Ownership doesn't mean being across everything or knowing everything or having the intelligence and data about everything that's occurred. It just means being the point of contact, the compassionate point of contact that simplifies the process of interaction. Yeah. Johnny's mum lost lost count of the number of contacts that she had to deal with. There's an opportunity to have a role in helping people move forward here. So that ownership and that accountability, that is super, super important. Taking ownership is also a really good, effective thing to do. When I used to work in an NHS trust, which I did for over 5 years, what we did was we met with stakeholders, so that's patient groups, local authorities, interest groups, Health Watch, GP practices, you name it, all the stakeholders within the system. And we gathered data. And we were seen as the point of contact. So we took ownership for that point of contact. If something was going wrong, a GP practice contacted us. If mental health service users weren't getting the right treatment, then the advocacy bodies got in touch with us. That helped us because having that point of ownership allowed us to be in charge, if you like, of developing a database. Some of it was qualitative, some of it was quantitative, but having that stuff, if you like, in one place was great because it enabled the organisation to understand what the common themes were. Yeah. So, when we talk about ownership and good recording, they actually help you. We used to use a CRM system, by the way. Some of you may be familiar with it. It's called Microsoft Dynamics. And we put all the information into that place with people's permission, of course. And that helped us, so when I talk about processes and coherence, this isn't all about emotion. That I understand the importance of processes and coherence behind the scenes. But it really does help you as an organisation, collate and understand all the issues that are emerging. We're going to get into some things you can do, and then we'll do some things to think about, some things to read, and then hopefully we will have a fruitful discussion. Super simple, isn't it? But really difficult to do. Make time and keep your promises. I know that sounds slightly naive on my part, doesn't it? But it entails a number of things. If you're going to keep your promises, then you have to make them. Yeah. So there's a precursor to that. So making time and keeping your promises is about engaging with people, telling them what you're going to do, how you're going to do it, when you're going to do it, when it's going to be done by, and keeping people posted. Yeah. I learned this, by the way, from years in sales and marketing. These are really, really simple things. The way to upset and lose a customer is not to keep them posted. You don't have to get everything right. You just have to keep them in the loop. Yeah. So make time and keep your promises. Don't fall into the trap of telling people you understand. I remember speaking to a very senior, actually, mental health consultant it was at the Patient Safety Congress in Leeds a couple of years ago. Sorry, Manchester. He was from Leeds, that's right. It was at the Patient Safety Congress, which is hosted by the HSJ in Manchester. And I started talking to him about my experiences. I didn't land them on him, I should say. He asked about them. And then he started to tell me that he understood. And so I asked him if he'd actually been through it. And he said, no. I said, well, how do you understand? And he just kind of looked at me as if, well, isn't it what I'm supposed to say? Aren't I just supposed to tell you that I understand? The answer is no, you're not. You can tell me that if you wish, but I'm not going to believe you. You can tell me that you will never understand. Yeah? Tell me that. I'll believe that. Tell me that you can't understand how I feel. I'll believe that. But please don't tell me that you understand, because unless you've got the T-shirt and been through it, you don't. If you don't know, say you don't know. Again, another golden rule, isn't it? Give people good quality information. Again, this comes back to the processes behind it. If you are going to send out packs to the families of people who have been affected, packs to families who might have made a complaint, whether it's through a care home or a primary care setting or whatever it might be, give them good quality information, up-to-date information, well-presented information. Let them know they matter. Coming back to this point about touch points, you'll be judged through those touch points, not through what you say you're going to do, but you'll be judged through how you do it. And let people know you heard them. Keep them posted. If you learn lessons, let them know. Involve them in a group, engage them with other groups, and then keep those groups in touch. Yeah. So if there's a patient advocacy group, keep that group in touch and feed back to that group, whether you're involved in what used to be called commissioning and is now integrated care boards, whether you're involved in NHS management or whether you're involved in the care sector. Let people know that you're acting on what they tell you. And if you're not acting, why you're not acting. Because sometimes, patient's family aren't always right. The customer isn't always right. Yeah. Some things to think about. So hopefully I've given you some practical things there that to do, and I appreciate you might want to discuss those in a bit more depth. But some things to think about. Who decides what poor care is? I think that's very much down to, yes, there are definitions and there are guides, and each person and organisation will respond differently to patient experiences. What I would encourage you to do when I say that is also please resist comparing an event with something worse. Well, at least, that's one of the worst way to open a conversation is to tell someone that things could have been worse. Comparison with the least good is not a recipe for improvement. Yeah. So, if your organisation has a pack of or pack of information that's updated and checked, we need to take ourselves to work each day. Yeah. And what that means is remembering who we are and what matters to us and those that we love. And so when I talk about it, is your organisation prepared? Have you got the processes in place? What if it was your favourite nana? Yeah. I pinched that off Daniel Pink many years ago, and it's one of my favourites because I think, actually, what kind of care would I want if it was my favourite nana? Yes, I have a favourite, or had a favourite, I should say. And if compassionate engagement is a product of how we do treat each other internally, how's that looking? Because you're not going to get one right without the other, yeah? So just bear that in mind. Some useful reading. Some of you may have read some of these books. Some of them are oldies but still goldies. These are I've probably read more books than is healthy for me. But these are 5 that kind of spoke to me about how you could perhaps get inside the mind of someone who's been through an experience of harm. On that note, I shall thank you for being attentive. Hopefully nobody's asleep yet. I will stop sharing my screen and we'll have some time for discussion, hopefully at least 10 minutes. And as previously, Jade, if anybody wants to stick around afterwards, that's absolutely fine. I'm not precious with time. I'm not going to chase anybody out the room. Any thoughts from anyone?
Fabulous. Thank you, Tom. I've just popped a link in the chat to the next session on the 3rd of April, which is around engaging effectively and building trust with external stakeholders. I've also screenshotted those things to think about and also the useful reading for the time being, because you will not receive the recording for this for at least a fortnight's time because I'm going on leave. So apologies for that delay. As Tom said, we do have some time now to take any questions from you, our wonderful audience. And also, if you'd like to stay on the call briefly after today's event finishes, you're more than welcome to. And I'm happy to leave you and Tom together as well, if you would prefer me not to be on the call. Over to you.
I'm never sure if it's a sign of great success or failure when people... Well, I mean, was it what folks were expecting? I mean, please be candid. I've got broad shoulders.
Do you have a question, Anne?
Yeah, well, it's not so much a question. Thinking about things to think about, who decides what poor care is. We do have a lot of standards out there, don't we, in terms of CQC, professional bodies, etc. And sadly, sometimes the coroner will tell you what poor care is, which is quite extreme. We don't want to go there. So I think public, if they grasp it, does have reference to a lot of standards now, to be honest. But I'm wondering, Tom, are you more thinking about it's about what's personal to an individual rather than a set standard?
It absolutely is, and it's interesting because I think I was hoping that we could, you're very much at the sharp end, and you were talking about, you're having to share with people and enter into dialogue with people who've experienced all kinds of levels of poor care. I think, let me bring this to life for you. So I sat with an organisation that was tasked with creating, some of you may be familiar with this thing called PSIRF, yeah, so Patient Safety Incident Response Framework. And NHS trusts were told about I think it's maybe 2 years ago now, they had to get this stuff in place and they needed to create a policy and a plan. And I was asked by the NHS leadership, hello Emma, I see we've got somebody there from the Leadership Academy. I was asked by the NHS Leadership Academy to work with a trust, who will remain nameless, on being what's called a patient safety partner within that process. And it was great. And it set off all very well. But we sort of reached this point where it became a tick box exercise. And compassion was yes, we must engage compassionately. But okay, what do we can we bring to life? What we mean by that? And what I found was that the whole process had become so rushed and so hurried. In the end, it actually amounted to, if somebody had a problem, they were going to be sent, and this is true as I'm sat here, they were going to be sent a copy of the PSERF plan and policy or a link to it. That's not compassionate engagement. I don't, if I'm in grief, any type of grief, I don't want to know that you've got a PSERF plan. It doesn't mean anything to me. It means something to you, but what it means to me shouldn't be what it means to you. What it should be to the NHS trusts that have it is the means by which they engage compassionately. It shouldn't be how they engage.
It's about
sharing your PSERF. Yeah. Does that make sense? Because I think you're right. There are standards, but many people don't know what those standards are. And standards of care are an incredibly personal thing, aren't they?
Yeah. I think organisational response is like having a policy. There is a complaints policy. There is this, there's that in organisations, but for people who, I don't know, there's something missing between embedding it in practice and about communication that goes with it. There needs to be more than telling people there's a policy that says if somebody does this, put it in writing, get consent, respond within so many days. It's all very procedural and not very human.
Absolutely.
And that's been my experience as a complainant. I complained about my daughter was in hospital for a month last year, and I was there, and they were very good in terms of she has additional needs. I could stay with her all the time, whenever. But unfortunately, they sat me in front of a sink in the bay, and
right.
So I saw how little it was used and observed very, very poor hand hygiene practice. So I raised it, and the response was completely inappropriate, and nobody listened.
Yeah. And it's even if they didn't agree with you, they could have listened. And I think that's the thing, isn't it? To take you seriously, even if they said, look, actually, I completely get it, but you know what? On our list of priorities, it's just not going to get done because there's something about how we engage and communicate with dialogue that you talked about. Yeah, there's something about that, isn't there? The amount of times I've had tried to have conversations with organisations, and I think the best one, and this is okay to talk about because they're not in the room, is the Crown Prosecution Service, an incredible organisation who at their best are the bee's knees, right? At their worst, let's not even go there. But you want a conversation and you're funneled into this process. And you try to explain to somebody at the start of it that if they could just have a conversation with you, we would all save time. Because we're going to go through a process, and off we trundle through this process. And I remember one particular instance where it took me 18 months to get the information that I wanted, from first requesting it via a conversation to then have it being shunted through processes to 18 months, by the way, isn't particularly long for some of the things I've had to get. But and you keep trying to tell people and say, look, I just want a conversation with you. Could we not? I'm not going to shout at you because I understand we've all got jobs to do. But, where are we with this and why did this happen? Right. So that sounds like a complaint. I said, no, it's just a conversation. I said, if you engage me in a process, it's going to become adversarial. I'm going to be like on one side of it. You're going to be on the other. And actually what we're then, our positions and our perspectives change. You're there to defend and I'm there to try and find my way through the defences. And it shouldn't be like that.
Yeah.
We should both be there to understand. And actually, because if we did that might change future engagements. It would save a whole lot of time and money. That might sound a little bit la-la land, but I do believe that we generate a whole lot of failure demand in healthcare services because we don't just let people have conversations, we shunt them through processes. So we end up with legal departments, filters, processes, you name it, and on it goes. Sorry, that was a slightly lengthy answer, but hopefully it makes sense.
Natalia, you had your hand up?
Hello, Natalia.
Sure, she's there still. Perhaps not. Oh, there she is. Yeah,
I'm here. I just it raised a question, this conversation, and I wonder how you would look at that situation. So I was involved in teaching, and I've been asked to review paper. And the paper was about the incident, the disaster, what happened in the 80s in the UK when people were transfused wrong blood, and a lot of people died. And then it was all hidden until recently. So it's all brought up just in May this year. It will be all reviewed again. And I think, is it a culture change, or is it everything? Is it any movement from what is the standards of care? This is the first question. And the second question is, when I like argument in a paper, and it wasn't any, it was just facts. So I Googled, is any similar disasters happen elsewhere? And I found in France in 1999, it happened, similar event. It what happened? The people who were in charge of that NHS, they were put in prison for manslaughter. So it's how France dealing with the cases like this. And I think that is a cultural way of dealing with that. For example, in my culture, it's all will be hidden, and it probably will never reviewed. So I think in Britain, it is a movement, and I think it is a change. But in France, they do it very harsh way, and I think society accepting that. I think it's an element of cultural way of approaching things. Am I right? I don't know.
I think we're it's wow, where to begin? How long have we got? Culture, I mean, culture change is that thing, isn't it, that everybody talks about, that we need and that we know we need. It's the most difficult thing to achieve. And if culture comes from the top, we'd have to recognise that most healthcare services are essentially, the culture comes from politics, doesn't it? Where they tend not to answer down, everything is answered up. And so there's an imperative to protect reputations. So rather than build the reputation on experience, and please, folks, please don't see this as criticism. I'm if you're looking for a fan of the NHS, then look no further. That's me, massive fan of I think it's the greatest achievement this country's ever accomplished. Probably one of humanity's greatest achievements. But the culture, though, does need changing drastically. I think there's perhaps also something there about sort of polite British culture, isn't there, where we don't actually tell things as they are, we don't say things as we see them or feel, and we strip the emotion out of things. And what I mean by that is, there's a guy I've spoken with a couple of times, very nice guy called Nicholas Gruen, who runs a very well published blog on the website, and he's been a civil servant in Australia for many, many years now. I think there's something refreshing about, and this is a sweeping statement, isn't it? And he would say that, wouldn't he? But there's something about the way the Aussies speak to each other and speak to other people that's very disarming. It's the F word comes out regularly, and they just kind of call it. And if you want an example of that, you've got to look no further than Bishop James Jones' report into what happened at Gosport, where I think it was Gosport report, where he talks about and you're talking up there about how people are punished for things and held accountable for things. He talks about clinicians who essentially misled inquiries and misled patients and misled other people as engaging in what he calls clinical collusion. A fascinating phrase, isn't it? Clinical collusion. But it sounds so polite. It's such a nice thing, isn't it? Because the nice doctors, they would never lie, would they? The professional people, they would never lie, would they? And I try to imagine if perhaps in some inner city housing project, if we would allow people to get away with crimes, dressing them up as, peer collusion, teenage collusion, crimes where the impact has been actually less than many of the things that we've had, whether it's the blood scandal that has just been outlined, or whether it's what happened at Gosport and other places. But there's something about the way we talk in reports that doesn't really pull out the elephants in the room. And the guy, my friend from Australia, what he says is that every inquiry is in essence its own cover-up. It doesn't mean that that's done in a malicious sense. It's not a deliberate sense or an evil sense, whatever those words mean. But he says that actually because the same people engage with the same narratives and the same command of language and the same words and many of them from the same backgrounds and organisations, because they engage in the process of holding inquiries, the inquiry really can't come up with anything new. And there's an injustice done to the people who really have the knowledge that needs to be fed into those inquiries, because that's never allowed into the process. And so what happens is we end up with these kind of, Robert Francis's report, which I think is a very polite report, Bishop James Jones' report, which is a very polite report, into actually what are pretty tragic, fairly damning events. And I also think, sorry, go on. Sorry, Natalia, what were you going to say?
So sorry, I just moved my book. I didn't mean to say anything.
No, it's okay. I was just saying that there's a cultural piece, you're right. There's an organisational cultural piece, there's a public sector cultural piece, because I found in my time in the private sector, the culture is very different to the public sector. Again, let me bring that to life. I'm about to give you a yawn moment, because most of you will have heard me talk about my time working for Carlsberg, but Carlsberg was a flat organisation, and the people at the top of that organisation wanted to know what was happening at the front line. They wanted to know. There was no sense of wanting to put their fingers in their ears and not know. And the reason they wanted to know was that the market forces that they were working within wouldn't excuse them being ignorant. If the products weren't right, if they weren't being received well, if the marketing campaigns weren't right, if the adverts weren't hitting the spot, if consumption wasn't rising in the right ways, in the right trends, and all those, whatever we think of alcohol consumption, just think of it as a product. But I can tell you from experience, I learned a lot from Carlsberg that I would never have learned in the public sector. But there was a desire to want to know what was actually happening. And I found in the public sector, when I joined the NHS, and just between Carlsberg and joining the NHS, I spent 10 years as a small business advisor. Not that I'm small advising businesses, I'm actually 6 foot, but I was advising small businesses. And what I found was that when I joined the NHS, there was this kind of, please don't tell us what we don't want to hear, because there's nothing we can do about it. And I remember we did this survey with the local GP practices once, where we brought the results back into the directors and the non-execs, and I think the governors as well, because it was a foundation trust. And what the chief executive did was he changed the colours on the graphs so they didn't look so bad, and then he presented it to the directors, because he said he didn't want them to see this bad news. And I was kind of like, well, what was the point of asking those questions if we're actually just going to hide it? It's not. Because for me, you see, I think this is it might sound pompous, but I think it's just a grown-up thing. It's just an adult-to-adult thing. We need to have adult-to-adult conversations where we can say, look, this is how this is what perceptions are. This is what people think of our services. And it's not good or it's not bad. It's just the place to start. And I think there's a beauty in marketing. I don't mean marketing as in, balloons and T-shirts and that nonsense, but I mean genuine marketing where you're trying to find out and understand what matters to customers and consumers. There's a beauty in that, because organisations that do that genuinely, they want to know, because they want to improve. And I appreciate that those pressures don't exist in the NHS, but they will actually, if we've got people on here from the care sector, they will exist to a bigger degree in the care sector than they do in the NHS, because care homes are in some respects competing with each other. I appreciate slightly differently, but there's when you ask about culture, there are so many factors to take into account there, Natalia. And I know that's not an answer, but it's probably raising more questions than answers. And again, as ever, happy to engage in emails afterwards if you want to discuss further.
Thank you, Tom. And that leads nicely on to the next session as well, when we're talking around engaging with external stakeholders. So I think you've just laid the foundations nicely there for a deeper conversation next time. I appreciate it's gone 3 o'clock. Thank you for those that have continued on the call with us. I am going to turn the recording off now. And if you would like to stay on